urologist in Bombay Hospital. So I would like to tell you about the ceftriaxone sulbactam plus EDTA drug that Cipla company has. So it shows the resistance in India, the resistance to various organisms that are present in normal public. So the resistance, you can see that 51% maximum resistance is to E. coli, then to Klebsiella is 34%, Enterobacteriaceae is 6%, and rest percentage is to the other organisms. And in the next drug, we can see that Pseudomonas has 52% resistance and 45% is to Acinetobacter. So these are the normal resistance in the normal public of India. Now the mechanism of resistance, there are two mechanisms. It could be non-enzymatic or enzymatic. Non-enzymatic resistance could be because of degradation of the antibiotic, alteration of the antibiotic binding targets, or expression of efflux pumps. Otherwise, enzymatic resistance is because of the action of beta-lactamases, which are 4 classes, which are shown in the figure. Now, there's an antibiotic resistance breaker. The antibiotic resistance breaker, along with the old antibiotic, makes new antibiotic. So they are capable of resensitizing the resistance bacteria to antibiotics. It targets multiple resistance mechanisms. The EDTA that they have added, it aids in better penetration of the drug, increase periplasmic concentration, so increase the activity. It leads to degradation of the biofilms that are formed, inhibition of transfer of antibiotic resistance by conjugation, and inhibits the efflux pumps. The synergy of ceftriaxone sulbactam and EDTA was obtained at a ratio of 2:1, which enhanced the increasing concentration of disodium meditate, and maximum synergy was found at 10 millimole of disodium meditate, suggesting that they both are synergistic. Now, the decreased antibiotic accumulation via enhanced expression of drug efflux pump is the major reason for resistance in gram-negative bacteria. So when 10 millimole of EDTA was added with ceftriaxone sulbactam, 32-fold reduction in minimal inhibiting concentration was noted, whereas meropenem with 10 millimole EDTA demonstrated only 8-fold decrease in MIC. This is the concentration given below. The modifying enzyme inhibitors are used to disrupt the bacterial detoxification enzymes, increasing the effectiveness of a co-administered antibiotic. Two major classes are BLIs and aminoglycoside modified enzymes. The membrane permealizers. Membrane permealizers can function by chelating and removing divalent cations from the outer membrane and associating with negatively charged outer membranes to disrupt it, causing a breakdown of outer membrane structure. The EDTA in ceftriaxone sulbactam inhibits the calcium ATPase-dependent pumps, possibly via their direct interaction with the pump, and reduction in the transmembrane potential, and thus enhancing the susceptibility of E. coli efflux over express strains. This is the compound formula of ceftriaxone sulbactam and disodium meditate. So they have a sulbactam that is an irreversible beta-lactamase inhibitor, and non-antibiotic adjuvant antibiotic resistance breaker that is disodium meditate. Now the mode of action of this drug. You can see it increases the membrane porosity. It downregulates the efflux pumps. It prevents the bacterial conjugation and downregulates the ESBL production chelate and the Zn ions in the MBLs. This shows that elores penetrated the outer membrane of E. coli with permeability coefficient approximately of 1.8, 2.2, 6.9, 2.5, and 2.3 times higher than imipenem plus elastin, meropenem, polystine, cefoperazone sulbactam, piperacin plus tazobactam, respectively. You can see that elores has the maximum permeability coefficient. Now, the efflux pump inhibitors, they act to decrease the intracellular concentration of antibiotic for pumping the antibiotics out of the bacterial cell, thereby reducing their effectiveness. So the maximum reduction in minimum inhibition concentration, that is approximately 32-fold, was noted with CSE 1034, that is the drug. Probably it caused a strong inhibition of efflux pump. As a result, increased accumulation of the drug within the bacterial cell. So because of that, it shows the maximum action on the bacteria. This drug could be one of the best choice to treat infection caused by microorganisms that overexpressed this enzyme as compared to the other drugs. This one, CSE 1034, is the drug that we're talking about. Ceftriaxone plus sulbactam. Okay. So what are bacterial biofilms? It is an architectural colony of microorganisms within a matrix of extracellular polymeric substance that they produce. EDTA disodium causes disorganization of the biofilm as well as makes the cell wall more porous, probably by chelating the divalent ions, thus enhancing the entry of the drug into the bacterial cell. Elores treatment leads to significant disorganization of biofilms and disrupts the biofilms. Here you can see the role of ceftriaxone plus sulbactam in E. coli biofilm destruction. So there's significant disorganization of the biofilm and formed a honeycomb-like structure of disrupted biofilm. You can see here. Bacterial conjugation. EDTA exhibits a significant inhibition of DNA relaxases enzyme activity because of chelation of metal ions required for the activity of relaxases. Thus, elores prevents bacterial conjugation and plasmid transfer effectively, and hence development of bacterial resistance occurring due to transfer of the plasmid DNA. Now, the inhibition of DNA relaxases by elores to control spreading of resistance gene through conjugation. In vitro relaxases activities were inhibited in a concentration-dependent manner, and complete inhibition was observed at 10 millimole of EDTA. So, EDTA, a non-antibiotic adjuvant at 10 millimole and above, exhibited significant inhibition of DNA relaxases. Elores also inhibited DNA relaxases due to presence of EDTA as a non-antibiotic adjuvant. Now, the spectrum of activity, major activity is shown against the Acinetobacter, E. coli, Pseudomonas, and Klebsiella, and against a wide range of ESBL and MBL producing gram-negative pathogens, and is used as a treatment option for multitude of bacterial infections. And we've seen that these are the organisms which shows the maximum amount of resistance in the general public. So this shows the minimal inhibition concentration and AST for various pathogens. Now, here we can see the minimal inhibition concentration and periplasmic concentration of the various drugs. So we can see that elores penetrated the outer membrane of ESBL, producing resistant E. coli with permeability coefficient of 1.8, 2.2, 6.9 as compared to imipenem, celestin, meropenem, colistin, cephalosporin, sulbactam, and peptaz. So this shows that it is the maximum is shown by the elores. It also has good catalytic activity against the metallo-beta-lactamase. You can see with the drug, it has the least. The graph shows that this is least, so it has the maximum catalytic activity. Elores also had the least degradation and maximum stability against the ESBL enzyme produced by E. coli resistant isolates. It is the least here, while other drugs such as imipenem, meropenem, colistin, peptaz has a very high physiological efficiency. Now, this was a study of pharmacokinetics and pharmacodynamics of elores in complicated urinary tract infection caused by extended spectrum beta-lactamase strains. There were 12 subjects with 7 male and 5 female in the study. All subjects were positive for severe UTI caused by ESBL gram-negative bacteremia and were evaluated for pharmacokinetic and dynamic and safety analysis. The indices shows that the minimum inhibition concentration and velocity max upon minimal inhibition concentration were calculated for each subject. This shows the pharmacokinetic parameters for ceftriaxone, elores, and plain EDTA. This is a very small, I don't think that we'll be able to see it. Yes. So by all the graphs that it is shown here, the pharmacodynamic or kinetic indices of combination therapy like elores should be seen in entirety rather than explaining the efficacy on the basis of single index. From the indices we've seen and the minimal inhibition concentration required, it is recommended that elores of 3 gram single dose per day can treat mild to moderate UTI, and elores 3 gram twice a day can treat severe UTI caused by resistant strains. So now this is the channel which shows the fixed dose concentration of ceftriaxone against the sulbactam. So we can see that ceftriaxone, the plasma concentration decreased over a period of time and reached minimal in 24 hours. But for sulbactam, the concentration decreased to 0 within 4 to 6 hours only. The same study by Suresh Attili and Chaudhary M. Pharmacokinetic and pharmacodynamics of elores in complicated UTI infection caused by extended spectrum beta lactamase. This was the population pharmacokinetics of fixed dose combination of ceftriaxone and sulbactam in healthy and infected subjects. So the efficacies of various fixed dose combination dosage regime over a wide range of MIC were assessed by Monte Carlo stimulations using population pharmacokinetic parameters on infected healthy subjects. In infected subjects, 3 gram concentration per 24 hour can treat bacteria with MIC of less than 8 microgram, while for MIC of 8 to 32 microgram, 3 gram of fixed dose combination per 12 hours is recommended. That's what we talked about. The Monte Carlo simulations for 1,000 adult subjects were performed to determine how likely the FDC dose of 0.75, 1.5, 3, 6, and 9 gram would achieve 70% combination at different values of minimal inhibitory concentration, that is 1, 4, 8, 16, 32, and 64 microgram per ml. So this is an original article from a journal, a randomized open-label prospective multi-center phase 3 clinical trial of elores in lower respiratory tract and urinary tract infection. The aim of the study was to study the clinical and bacteriological efficacy as well as tolerability of ceftriaxone plus disodium erytate plus sulbactam, that is the elores. In the treatment of LRTI and UTIs. So the method, it was a randomized open-label multicentric study. Number of patients were 297. It was assessed for a period of 10 days. And 3 gram elores was used twice daily. And for half the people, 2 gram ceftriaxone was used twice daily for UTI and LRTI. Patient selection was adult patients more than 18 years and less than 65-year-old with signs of LRTI or UTI was screened for enrollment. Approximately 306 patients were enrolled with clinical evidence of LRTI UTI infection in 9 centers across India, in which 297 patients completed the study and 9 were dropped out. Study design was a multicentric prospective randomized open label study. Patients were randomized assigned into 2 groups, those receiving elores 3 gram twice daily and those administered ceftriaxone 2 gram twice daily. Both the drugs were administered intravenously for 3 to 7 days. Inclusion criteria was LRTI subjects by presence of signs and symptoms of acute respiratory infection such as cough, nasal discharge with fever or without fever, and low respiratory signs such as tachypnea, retraction, prolonged respiratory time. Exclusion criteria was subjects with clinically significant cardiovascular, renal, hepatic, GI, neurological, psychiatric, or severely immunocompromised patients, or history of uncontrolled diabetes, HIV, or hepatitis B. The microbiological investigation that was done was sputum, blood, and urine specimens for uterine culture and pathogen-resistant gene characterization were obtained within 24 hours prior to the start of treatment. Gene characterization, a PCR assay was performed to detect ESBL and MBL encoding genes using the specific primers, namely TEM1, TM2, TM50, and all this. The results, the clinical cure rate for elores group were 83% as compared to ceftriaxone that was only 34%. The eradication of bacteria rate was 95 for elores and 80 for ceftriaxone. So conclusion was that elores is more effective and safe antibacterial agent for the treatment of LRTI and UTI. Okay. So this is another study from another journal which compares the function of elores versus meropenem for the treatment of complicated UTI, including pyelonephritis. It's a double-blinded, randomized trial. The results of this trial was non-inferiority of CSC to meropenem was demonstrated for both US FDA defined co-primary endpoints of symptomatic resolution at test of cure 71 of 74 patients, that is 95.9% patients versus 62 out of 69. Symptomatic resolution as well as microbiological eradication was in 70 out of 74 for elores and 60 out of 69 for ceftriaxone, meropenem. Microbiological eradication was obtained in 70 of 74 versus 61 of 69 for meropenem. So the conclusion here that we've met is that the elores met the primary objective of showing non-inferiority against meropenem in the treatment of patients with complicated UTI, including acute pyelonephritis. The susceptibility profile of pathogens isolated in this study highlights the increasing antibiotic resistance trend and warrant a need for new effective antimicrobials. The results support the use of CSC as a potential alternative to carbapenem in the treatment of patients with chronic complicated UTI or acute pyelonephritis, including infections caused by ESBL producing gram-negative bacteria. Now we have a case in which we're discussing a case about a 64-year-old male patient presented to the emergency department in an unresponsive state with altered sensorium the last 2 hours. Patient has a continuous high-grade fever associated with chills. The patient did not complain of any rash or diurnal variation. He had decreased urine output dysuria for the past 5 to 6 days. Patient also reported breathlessness in 5 days, which increased on lying down and was associated with coughing. But no sputum or expectoration was reported. Past history, he is a known diabetic for last 25 years with diabetic nephropathy and hypertension since last 6 years. No history of any urinary instrumentation or surgery in the past. Before presenting to the hospital, the patient was also taking oral antibiotic cefixime 200 mg twice daily for last 4 days. On physical examination, the patient was A4 respiratory rate was 20, heart rate 64, BP 90 by 60. Saturation was 94% on room air, and blood and urine sample was taken and sent for routine blood and culture sensitivity. Provisional diagnosis of UTI with septic shock with complicated acute kidney injury was made. So now the patient was started on broad spectrum antibiotics including piptaz with teicoplanin 400 mg IV stat along with inotropic support. Central line was inserted for central venous pressure measurement and fluid management, and the patient was shifted to ICU. The reports that came was deranged TLC count 15,000. He had high ESR, differential leukocyte count was 92, 3.6, 3.9, 0.4 and 0.1. Urine analysis showed the presence of pus cells 30 to 35. RBCs was 70 to 80. Proteinuria and hematuria. X-ray was taken in PAView which revealed cardiomegaly with bilateral pulmonary embolus and prominent bronchovascular markings. USG showed bilaterally decreased kidney size with increased ecotexture, mild ascites, and mild bilateral pulmonary effusion, and corticomedullary differentiation was also deranged. A 2D echo was done showing normal ejection fraction and concentrated left ventricular hypertrophy. After 48 hours, the patient condition deteriorated further instead of improving. Urine culture showed E. coli, resistant to piptaz and sensitive to meropenems. Based on the culture sensitivity report, piptaz was stopped and patient was started on elores, that is ceftriaxone, sulbactam and EDTA, 12 hourly, and teicoplanin was also discontinued. After 3 days, the patient responded to the treatment and his condition started improving. Hence, he was continued on elores 1.5 gram every 12 hourly for 11 more days. Additional peripheral support was given for metabolic acidosis. Insulin infusion was given also to maintain steady glucose level, and norepinephrine was gradually tapered off. After the completion, patient showed tremendous improvement. Repeat blood reports were done on 16th day. TLC count decreased to 6,000, and other parameters also were normalized. X-ray was done, no effusion was there. More examination, the heart rate and BP, the heart rate increased to 85 normalized level, and the BP also rose to 110 by 70. And on the 7th day, the patient was discharged, which follow-up advice was 7 days. So this shows that elores was superior in the form of treating complicated UTI as compared to piptaz and teicoplanin. But there are some of the adverse effects seen with elores, that is diarrhea, loose stools. Patient can have dyspepsia, nausea, vomiting, local phlebitis, edema, pain, swelling, itching, headache, and dizziness. But these are very mild adverse effects that are seen with most of the drugs. So this shows the superiority of elores in the treatment of complicated UTI. So this is the whole motive of this webinar, and I'm very thankful to Simla Papers to invite me.
Thanks, sir. Thanks, Apoorva, sir. Dr. Bitan Sen, sir. Sir, you would like to anything on this?
Very nice, Dr. Apoorva. Very nice. Yeah. So in the ICU, as you can see, I'm an intensivist, Dr. Bitan. So in the ICU, the case which he had presented, such patients come to us, and actually we face a lot of challenges in such situations. So correctly, the antibiotic was changed to elores, and as we could see that instead of starting with a higher antibiotic, means instead of starting with any other antibiotic, elores was started, and so the patient started responding, and also thromboprophylaxis must have been given because he was having thromboembolism, pulmonary embolism. So the patient responded. Another thing is the in the side effects, EDTA is included in this drug. So hypocalcemia, hypomagnesemia, hypokalemia tends to occur in such patients. So we should monitor the electrolyte abnormalities in these patients. Although it doesn't occur frequently, but it can occur, and in such cases we can get something called as the torsades de pointes, which can lead to sudden cardiac death. So we should monitor these electrolytes while giving this antibiotic. Another thing is the biofilm formation, which occurs in the urinary catheter which we insert in such patients. So once the biofilm develops, that means means very few antibiotics are going to act on that, and it's very difficult to very difficult to treat the patient. But again, in this situation, elores comes to our rescue, and that breaks the biofilm. So essentially, elores along with the EDTA, it's a powerful combination.
Yes, yes. Definitely, urologist works wonders. So good.
Thank you, sir. From audience, anyone has question can put up in chat box. If anyone have any question, then
It seems it was very evident from all the studies that you showed that your drug is superior in terms of composition as well. So thank you everyone for attending the.
okay, sir. Thank you, sir. Thank you very much for your meeting was very good, sir. So thank you very much.
Thank you. Thank you.
Thank you so much.
Thank you, Dr. Bitan.
Thanks.
Thank you, Bitan, sir.
Thank you. Bye.
Thank you, Professor.